Thank you for the invitation to speak. I am a clinical researcher, and so I kind of think of my life as more of a bedside back to bench rather than a bench to bedside for my work. I like to first acknowledge our collaborators, Guishang and Yingzi. We torture quite a bit with data analysis, as well as Tomas for some of the electrophysiology that we do. And I'm going to talk today about a project that I'm a co-PI with Jeff Goldberg at Stanford University, but we collaborated on a large number of studies together in this space. This project was entirely funded by the Gilbert Family Foundation that has a focus on this in neurofibromatosis. I do some consulting work for Ovid Therapeutics unrelated to this topic. So Jeff and I are charged with identifying different opportunities for visual restoration or neuroprotection in children with NF1 optic pathway gliomas. And this is one of many talks, but we're trying to take a very comprehensive approach of understanding imaging and clinical biomarkers on children that have lost vision from their tumor. And so this encompasses structural, functional, adaptive optics, metabolic and mitochondrial imaging. But today I'm just going to simply talk to you about one small project looking at vascular imaging in these kids or in these adults. So here's a picture of two different types of tumors that are associated in neurofibromatosis type 1. This is the most common genetic predisposition syndrome in the world, occurring in about 1 in 2,500 births. So it is out there. And these children are predisposed to having low-grade astrocytomas of the anterior visual pathway. So along the optic nerves here, into the chiasm and the tracts that cause vision loss in maybe about a half or a third, where the other 2/3 do not experience vision loss from these tumors. So that's one of the clinical challenges. The biggest thing that we are still woefully ignorant about is the mechanism of injury. These are not extrinsic tumors that come in and press on axons and are compressive optic neuropathy, but they're actually inherent to the nervous system here and inherent to the anterior visual pathway. And so we don't think it's a compressive mechanism. There's a lot of immunologic markers and inflammatory markers, even by the chemotherapies that we use and bevacizumab, that show that it's just not a simple compressive mechanism. So in the spirit of understanding how do we support these axons that are dying, or how are we going to provide a neuroprotective therapy for a child at high risk for developing an optic neuropathy for the tumor, how do we provide the support, right? You just can't go in and instantly treat these beat up axons and RGCs and think that everything is just going to be fine. So this has led me down the path of neurovascular coupling, right? Where you have this great mechanism in the inner retina and neurons where you have some energy demand and your vascular system comes up, much different than the autonomic nervous system that subserves the outer retina. So if anybody that has chest pain or cardiac conditions, you get hooked up, you get all these different metrics to look at your coupling and your mechanism if you have heart disease. But where does that get a little bit more finite here? And so Cajal knew ages ago of just this exquisite nature between neurons and astrocytes and regulating this in a kind of an energy and blood flow meets demand. And so this is what I really wanted to understand, this local regulation within the optic nerve and how this reacts in children with optic neuropathies and people that have had vision loss from their tumor. So it's kind of like, so what? Well, yeah, you can look in this, but so what? But it has been shown to be disrupted, this balance between the right amount of blood flow in early stages of optic neuropathies, including glaucoma. So my thought is, maybe neurovascular coupling and how this goes could serve as a potential biomarker of risk progression. I think about Dr. Ross's normal pressure glaucoma patients. Is there something disrupted earlier on that shows that these are at higher risk for progression? Also, is it a therapeutic target for an intervention? As Dr. Mitchell talks, and implanting retinal ganglion cells and axons, are we going to have to do other things to make that a rich environment that these new RGCs or new axons can actually survive, and they're doing that? And lastly, and I think probably the lowest hanging fruit, is when we try visual restoration, not everybody's going to jump up 4 or 5 lines on the ETDRS chart or their visual field is going to get dramatically better. And there's going to be responders and non-responders almost in every disease, even when you look at stroke and the Penn ER. So understanding this as a potential variable of maybe this will help choose the winners and losers from therapeutic intervention. So I've been kind of on this mission to have a vascular stress test for the eye. Why don't we see where that lands in the health of the eye beyond just those axons and RGCs? I've read this paper by Newman numerous times over and over again, looking at the blood flow supply of the eye and the optic nerve. And here, they used to take single vessels in animals and look at the width of the artery or the vein on how it would change, why you're getting flicker stimulation, where you're doing kind of a VEP stimulus, and see how those vessels respond to that. But I'd really even go back further to Dr. Juan Grunwald here at Shea, who, along with Revis, has done some amazing work. I mean, these are articles from 20, 30 years ago, looking at glaucoma and others with technology that was so much more limited than what we have at our hands today. But I always just want to acknowledge Dr. Grunwald's work in looking at how the blood flow goes down. And they did some stimulation work with a very kind of limited effect of blood flow, where they look at very specific parts of the optic nerve. But technology has gotten a lot better now. And over the past 8 years, there's a device called the laser speckleflography, probably the worst name in ocular imaging, but I digress. But what it essentially does is shine a light into the field of view all over the optic nerve, the retina, everywhere. And the speckle patterns of the moving blood, of the moving RBCs, creates a great blood flow map that you acquire over about 4 seconds. And hopefully our video will work here. But you see it goes through the blood flow or the cardiac cycle for about 2 or 3 cardiac cycles here. It's glitching a little bit. That you can look at just the optic nerve head, you can look at the macula, you can look at arteries, veins, and a wide range of hemodynamic responses. It's not just simply peak, but what's that, where those pulses look like and things like that. So years ago, we started saying, how do we provoke the optic nerve here? And how do we provoke those RGCs to see a change in blood flow with these new methods? And so as you can see here, as the subject, we would take a blood flow measure, then we would sit with the VEP over our eye and then re-measure, which was less than ideal, but we looked at a lot of different stimuli, such as a photopic negative response stimuli in different VEP frequencies and intensities. And Harry Ong, who's now at UT Austin and is a neuro-ophthalmologist there, did a great study looking at all these different stimuli, looking at how long it takes, what kind of robust responses where we get from either a short stimulus or a long stimulus, where we see beautiful responses, both from a photopic negative response or type stimulus and a VEP type stimulus, whether it's short or long. And this was all done in healthy controls. But now Diagnosis, who's a common electrophysiology company out there, has this color flash that we can arrange and continue to provide any kind of visual stimulation here, primarily VEP and photopic negative response, that we can image the patient undergoing this and watch their blood flow response through changing the frequency or the stimulus or things like that. And so that's what this project has incorporated to look at neurovascular coupling in these patients. So our hypothesis was those patients with vision loss secondary to their tumor or an optic neuropathy from their tumor will demonstrate an abnormal or reduced neurovascular response during flicker stimulation. And so we had 4 cohorts that we looked at. The first one was those with the tumor with either visual acuity or visual field loss or both, and they clearly had an optic neuropathy. These are young adults mainly that showed on OCT of under 80 microns. But as I told you, there are kids and adults with tumors that don't lose vision despite having a tumor and don't undergo chemotherapy, and those were bona fide without vision loss and a normal OCT. NF1 is a huge gene that is a multi-system gene that does a lot of strange things throughout the body. So we wanted to look at those that were without tumors because their genetic makeup is likely a little bit different than those with tumors and those without, and obviously having some healthy controls. So beyond the basic visual acuity and visual fields and OCT, we excluded people with other ocular comorbidities, glaucoma, other kind of systemic or ocular medications that could impact their blood pressure or other changes in vasculature. So we'd collect a baseline LSFG, and then we'd start at 10 hertz flicker. And at 30, 60, and 90 and 120 seconds, all during this flicker, we would acquire the LSFG. And the flicker does not mess up the acquisition of the blood flow. Then we turn off the flicker and again collect blood flow measures over this time. Then we gave them a rest and then repeated this looking at a 1 hertz flicker, right? Some of it is walking versus jogging or running. It's in some ways to learn a little bit more about this. And we can look at specific just optic nerve head tissue here. The software on this is quite amazing to where you can look at just the tissue, you can look at just the vessels, and then you can look at peripheral vessels outside the optic nerve head in the superior and inferior arcades where you draw like ROIs on. But so this image captures everything in here that we can acquire. And again, we have a whole host of hemodynamic measures here, but we're going to mainly talk about blood flow. So cohort 1 here are the individuals that had visual field loss or visual acuity. They clearly have an impaired OCT with optic neuropathy. They have a lowered VEP amplitude and a much longer latency, confirming they have an optic neuropathy. So let's look at the data when we look at the optic nerve head tissue up here. On the y-axis is the change in the blood flow from baseline. And down here you see where the flicker starts, and then the delta is what we're seeing here. Now, the red line is those individuals in cohort 1 with vision loss that showed a suppressed neurovascular response compared to the other groups. As Dr. Ross pointed out, you're always surprised by the things that you don't expect, right? That's no great discovery was preceded by, oh, that's exactly what I expected. But the cohort 2 individuals with a tumor but normal vision almost had a hyper response in their blood flow, which it's hard to hypothesize. We know that they have these very hyperactive astrocytes in this disease, but these kids manifest normal vision, but have a very hyperemic response, almost over the top compared to normal controls. When we look at just the vascular response at the optic nerve head, the groups didn't differentiate much. So we saw lower blood flow, but they're kind of pumping out the same amount of blood flow at the time, but the tissue is getting less. When we looked at the superior aspect of the optic nerve head, again, during the flicker stimulation, this group 1 with vision loss is really suppressed and different. And then again, looking at that group 2 that have the tumor, but no vision loss compared to those with the same disease or controls, it's this hyperactivation of blood flow in the tissue. Nasally was a very similar story here at 10 hertz. And then temporally, again, we see a very similar pattern. So these are diffuse changes throughout the optic nerve head, as well as globally, where those with the optic neuropathy have declined. But the one thing that, again, we couldn't really make up is, again, these temporal optic nerve head vessels that are around there, are just the vessels of the optic nerve head, seem to have almost an opposite effect with the optic neuropathy, that they're almost oversupplying blood flow rather than undersupplying blood flow into the temporal optic nerve. We reduced then and went to a different experiment where we just did 1 hertz. And believe it or not, the differences weren't all that great. And I'm not going to go through and show you all the different values, but while there might be some subtle changes between groups here, kind of walking at a pace, if you will, didn't show too much difference between the groups. Certainly, clearly less so in the red group that's the optic neuropathy, but it was different than I would almost say the running aspect of it, of that 10 hertz stimulus. So what are the limitations? So the LSFG device almost has an arbitrary number. So it doesn't get an actual, milliliters per second or things like that. But that is that's just inherent to this kind of technology. Some of our subjects with the worst visual acuity had a hard time focusing on the fixation point in the device and doing the flicker at the time. And again, that's something we learned the hard way going through this. And then this device can be a little bit finicky in that blinking and doing stuff and moving the eye a little bit during the stimulation can throw off and have artifacts and errors. It doesn't have eye tracking like some of the newer advanced OCT devices. So in conclusion, those kids, or those adults, I should say, that had visual acuity or visual field loss and an optic neuropathy showed decreased tissue perfusion, but despite having relatively similar blood flow comparable blood flow. Also, for some reason, they had a persistently elevated temporal blood flow during and after flicker stimulation that seemed quite odd. And again, this is the surprise, is those that had a tumor that have normal visual acuity, normal axons, normal VEP, normal visual fields, had an exaggerated hyperemic response, kind of going towards the thoughts that these are very hyperactive or overactive astrocytes in the tumors that we think, or that are really in some way dysfunctional, if you will. So the next steps is really looking at these with different stimuli. We work with Tony Norsha, who's a psychophysicist at Stanford, where you can turn on and off different ganglion cells doing certain types of swept source VEP. And again, as we move forward with this foundation of including these measures in some of our neuroprotection and visual restoration to try to understand who are going to be our responders and who are not. Thank you very much.